So I just like to thank first the AIOC to give the uveitis a slot for the National Symposium. This is very good. I'm going to start with this symposium of infectious uveitis with the search for the cause. I'll take exactly 9 minutes, 30 seconds. Infectious uveitis search for the cause. Prompt and precise clinical diagnosis is quite important in infectious uveitis. And etiological diagnosis should be made as soon as possible because it needs rapid action to combat the infectious agents and preserve the vision. I just want to share with you what I do. I go through the history and old records with the patient bringing meticulously. If that patient is history is quite important, and that we join with the clinical findings and the laboratory investigation. I try to find out the systemic disease, if any, history of fever, dengue, typhoid, rickettsia, chikungunya. Is the patient immunocompromised? HIV or systemic malignancy? History of unprotected sex? History of IV infusion in case of endogenous endophthalmitis. Sometimes contact with the pet history is quite useful, like toxoplasma, toxocara. These are 30-year-old female, immunocompetent, and you can see that there is a whitish exudate material in the vitreous cavity. If we look at the history, this patient gave history of hospitalization in the recent past and had IV infusion. And the vitreous biopsy showed endogenous endophthalmitis. So what we thought that is a kind of a vitritis can be, with the history itself, can help us to make a diagnosis. I also look at the patient as a whole, and like this patient who has got a necrotizing retinitis with hemorrhage, 30-year-old female, immunocompetent. And looking at the face itself, we can see that the vesicles were seen on over the forehead. And this is the herpes zoster vesicle, Varicella Zoster, and indeed the patient had Varicella Zoster viral retinitis. And after IV and acyclovir injection, there is a marked resolution of inflammation. So this is a 30-year-old male HIV positive patient, and you have seen the retinitis with subretinal deposits. Subretinal deposits. And in the hand, you can see that the lesions on the hand in the palm, and these lesions are syphilitic rashes. And this patient indeed had VDRL TPHA positive, and the patient has syphilitic positive uveitis. So simple clinical examinations of the whole in the patient helps us to make a diagnosis. Serology, are they useful? Yes, in some cases like HIV and syphilis, I depend on the serology. But in the toxoplasma, clinical diagnosis comes first, and then confirmation can be made by the toxoplasma ELISA serology. Post-fever retinitis serology is quite useful. Dengue, typhoid, rickettsia, chikungunya. This toxoplasmic retinochoroiditis often have classic appearance with the retinitis by the age of a scar, or a retinochoroiditis with headlight in the fog appearance with localized vitreous haze. I make the clinical diagnosis first, even start the therapy before serology results comes. If I do the ELISA test only, but in case of HIV positive patients, when there is an atypical necrotizing retinitis, I add, along with other investigation, a PCR for intraocular fluid for toxoplasma. Ocular syphilis is often a challenge. It can have mimic any type of uveitis. I do serological tests, both non-treponemal and treponemal. Non-treponemal test is for state of activity, and FTABS and TPHA has had a high degree of sensitivity and specificity. This is a case of syphilitic posterior uveitis, and you can see the diagnosis can be made by both non-treponemal and treponemal test. And there is a marked resolution after intramuscular injection of penicillin. Tubercular uveitis, there is a big debate what should be done and what should not be done. It has got protein manifestation. Single test in my mind is not helpful. What I do, I make a clinical diagnosis first, like granulomatous anterior uveitis or multifocal serpiginoid choroiditis, where I suspect, or there is a broad posterior synechia, choroidal nodule, subretinal abscess. So I make my clinical diagnosis first, and based on that, I do the both Mantoux and quantiferon TB gold test, but both of them are supportive only to my clinical diagnosis. I do a HSCT test, particularly to rule out a TB and sarcoid, And then if negative, do anterior chamber tap, vitreous aspiration, even go for fine needle aspiration biopsy of choroidal mass lesion in strong suspicion. Subject to the PCR for MTB genome, I do both nested and real time. Roll-up HSCT, we do the rule-out TB and sarcoid. This is an example, 14-year-old girl, bilateral intermediate uveitis. It could be TB or sarcoid, but HSCT chest showed multiple nodules in the lung parenchyma, suggestive of tubercular etiology. Intraocular fluid study can often give the diagnosis, though it should be clinically correlated. Polymerase chain reaction sensitivity is around 80%, but specificity varies from 90 to 100% cases. This is a PCR machine. Is that report is ready within 12 hours. This rapid results helps us quite a lot in infectious uveitis. This is a case of 21-year-old female with granulomatous anterior uveitis of Marfan-Fed KPs, broad posterior and peripheral anterior synechia. Laboratory test was not very confirmatory. I did go ahead with the anterior chamber tap, and then anterior chamber tap showed PCR for mycobacterium tuberculosis, both MPV64 and IS6110 region positive. This is a case of subretinal abscess, and we suspected an infectious etiology. We take a fine needle aspiration biopsy, and this biopsy specimen was subjected for various organisms in PCR test. FNAB specimen for PCR for MTB came positive. And then after the treatment with the anti-TB and steroid, the patient had complete resolution of inflammation with marked improvement of vision. Real-time PCR is an advancement in the PCR technique. Here you get the copy number of the amplified DNA. Fluorescent molecule is used to monitor the PCR reaction. I do the increase of viral anterior uveitis, clinical suspicion first, often very high IOP, pigmented KPs, ACTAP for PCR, HSB1 and 2, VZB, CMV I do, and both nested and real-time PCR I do it. So real-time PCR can be helpful in recurrent cytomegalovirus anterior uveitis, where the resolution of the treatment can be attained with the real-time PCR monitoring. This is a curve showing the real-time PCR positivity with the anterior chamber fluid. In case of viral retinitis, which could be acute retinal necrosis, herpetic necrotizing retinitis, CMV retinitis, and this ARN is often have a classic appearance like peripheral necrotizing retinitis with wedge-shaped appearance. To do that, to find out what virus is there, I do the AC tap when there is AC inflammation, or vitreous biopsy if no AC inflammation. I do both nested and real-time PCR for herpes viruses, and sometimes if there is a doubt in the diagnosis of necrotizing retinitis, I add toxoplasma also. This is a case of acute retinal necrosis. I can see the necrotizing retinitis in the periphery with retinal hemorrhages and wedge-shaped appearance. We did a nested PCR as well as the real-time PCR. Nested PCR showed HSB1 positive, and the real-time PCR showed 88,000 copies of the herpes simplex virus type 1. The outcome of the polymerase chain reactions, the analysis of 100 suspected cases of infectious uveitis, confirmed or provided diagnosis in 70% of the cases. This is a case of a cytomegalovirus retinitis, which has got often a characteristic appearance. And I do that test for HIV and CD4 cell count and take history of HIV and organ transplantation. Post-fever retinitis serology is quite useful. Rickettsia, dengue, chikungunya, typhoid, and consultation by infectious disease specialist when there is other system or involvement. And PCR for chikungunya is quite helpful. This is a patient with 48-year-old male with history of fever 3 months back, multiple areas of retinal exudates with hemorrhage. We did the PCR for several organisms. 9 copies of chikungunya virus was found, and this with the treatment of steroid, there's a marked resolution of inflammation. Last but not the least is Masquerade syndrome, where biopsy is mandatory. We do the vitreous biopsy, and this specimen should reach the pathology lab within 30 minutes. And there is a necrotic background. You can see the abnormal lymphoma cells. In case of vitreous biopsy negative, we can do a fine needle aspiration biopsy. Here in necrotic background, we can see the large lymphoma cells, and CD20 is positive. Retinal or retinochoroidal biopsy is required in a very recalcitrant cases and when other diagnostic modalities fails. And this is a case of necrotizing retinitis, which you can say necrotic retina toxoplasma gondii organism. What's new is that in metagenomic deep sequencing identify common and rare pathogens. And last but not the least, a new thing, MemoID 88L265-265 mutations, which can be seen in the primary intraocular lymph node. So take-home message is a good clinical history. Look at the picture as a whole, look at the patient as a whole, make a short clinical differential diagnosis, correlate with lab tests, take the help of infectious disease specialists in multi-system involvement, do invasive test, intraocular fluid or biopsy when in doubt or in strong suspicion, and don't miss endogenous endophthalmitis and Masquerade syndrome. Thank you.